today. We're going to be talking about what we can do to take care of ourselves, make sure that we understand what stroke is and what we need to do to help prevent either from having a first stroke or if we've already had a stroke, what we can do to keep from having a second stroke. My name's Suzanne Hefton. I am the stroke coordinator for the Crozier Health Hospitals. I still want to say Crozier Keystone. So I cover Crozier, Taylor, Springfield, Delaware County. And so a couple of statistics about stroke. So here in the States, about every 40 seconds, somebody has a stroke. So if you think how many periods of 40 seconds did we just spend trying to figure this out? Think about how many people that would translate to having a stroke. We also know that about every 4 minutes in the state, somebody dies from a stroke. So again, 4 minutes is brushing your teeth and brushing your hair. So in that period of time, somebody dies from a stroke. So it's pretty prevalent. It's going to be you, your friend, your family member that we're going to be trying to help today. We know that there are 800,000 new strokes a year. This number is growing, so we really have to put our efforts towards prevention. The exciting thing is that it's now the 5th leading cause of death. About 5 years ago, we were still the 3rd leading cause of death for stroke. So we've made huge impacts in the treatment of stroke. So folks are not dying from it as much as they were in the past, but it's this number we have to start trying to impact. Probably the scariest part about stroke is, if you're going to have a big stroke and die, okay, but you don't die. You end up in a nursing home. You end up not being able to take care of yourself. You can't feed yourself. You drool. You're incontinent. And to me, I think it's probably the scariest thing for folks. Another really important piece of information is 80% of strokes can be prevented. There's very little other illness or disease or condition that we can say we could prevent 80% of them occurring if we kind of were able to manage lifestyles and, follow a couple of good, healthy lifestyle habits. So, in real estate, location. So in the stroke world, high blood pressure is the number one risk factor and cause for stroke. In 2017, the numbers changed. So now, if you have a blood pressure of 130/80 or higher, we now classify you as having high blood pressure. Number one risk factor for having a stroke. We also now know with all the new technology we have AFib, which is kind of an erratic heartbeat. It can last for seconds or hours or days. We know that folks that have AFib, their risk of stroke is 5 times higher. And the reason for that is when the heart beats erratically like that, very tiny clots form, just like the size of a pinhead, and then they travel up into the brain. So very, very prevalent. If you have AFib, you need to make sure you're managing whatever your medications are and staying on top of that. We also know that African Americans have a much higher incidence of stroke, and that is directly related to the higher incidence of hypertension. We do see a specific type of hypertension in African Americans. We refer to it as malignant hypertension. It's very difficult to treat, so puts them at a higher risk for stroke, for diabetes, for kidney disease, et cetera. We also know sickle cell is a risk factor for stroke. We also know that the strokes that African Americans have tend to be worse, and they have worse outcomes. Women in stroke, women actually have a higher degree of disability when they have their stroke. So if you kind of think of that in terms of women being primary caregivers. So think about women having strokes. They will not be able to be a caregiver after that stroke. So really important that as women, we do everything we can to prevent a stroke. We are now starting to see a higher number of strokes in women that are right in that middle age, 45 to 54 years old. And we think that really it's, there's an increase in smoking, an increase in sedentary lifestyle, and they just aren't taking the steps they need to prevent the stroke. In the Hispanic population, we see strokes starting at a younger age. We're not real sure why. A lot of work is being done to try and figure that out. We do see in that population lots of issues with them being able to get to health care. So a real lack of either caregivers and providers in their areas, or they don't have transportation, or there may be language barriers. So what is stroke? Stroke is a lack of blood flow to the brain. So that can occur either we have a little clot that I mentioned with AFib, there may be a spasm in the blood vessel, or the blood vessel may burst. But it's a lack of blood flow to the brain that then results in damage to the brain tissue. So we have two types of strokes. One, we call it an ischemic stroke. So that's a clot, a piece of either plaque from the carotid artery, or a little clot from the heart breaks off, it travels up into the brain, it gets stuck, and then the blood can't get past that clot. The majority of strokes that happen in the States are this kind of a stroke due to a clot, about 87%. The other type of stroke that we see is what we call hemorrhagic stroke. People refer to this as a brain bleed. This is due to the blood vessel rupturing and the blood flows out. And if you think about your brain, it's a hard shell. Your skull can't expand. And because of that, the pressure from this bleeding into the brain is often fatal. Folks that have a hemorrhagic stroke do not have good outcomes. That is a really kind of bad stroke to have. So TIA, to me, this is where we really need to focus our efforts in the stroke world. TIA is transient ischemic attack. I really would like for us to go back to calling it a mini stroke, because if I tell my uncle that, you're going to have a transient ischemic, he doesn't listen to that. If I say a mini stroke, man, I have his attention in a heartbeat. So I think if we could really get folks to understand that a mini stroke, stop calling it TIA. It's a mini stroke. I think that kind of gets their attention a bit more. So what happens with a TIA or a mini stroke is we still have a blockage, but it's only temporary. So the blockage goes away. Either the clot travels all the way to the very end of that blood vessel, or it breaks up, or the spasm that was occurring, that vessel releases itself. We know that there's not permanent brain damage done, but we see when we do MRIs on these people, we do see subtle changes in that brain tissue. Here's the thing. If you've had a TIA, you are what we call front-end loaded to have a stroke in the next 3 months after that TIA. So this is the person who's at the grocery store shopping, maybe they're getting produce. They're looking at the apples, checking out what one they want, and the apple drops out of their hand. And they're like, well, what just happened? And they're kind of looking at their hands like, oh, wait a minute, that apple was in my hand. How did that, kind of confused, not sure what's going on. They wait 2 minutes, it gets better. They go home, they tell their daughter, who's a nurse, what happened. And you're like, what the heck? So when those types of episodes happen, it's happening because there's this brief blockage of blood flow to the brain. We have a stroke symptom. It gets better, and then people don't seek care. Well, if you don't seek care, you are going to have a stroke in the next 90 days, I could almost bet on it, right? The odds are hugely in my favor that I would win that bet. So it's sort of like a warning sign. It's a gift from God. It's like, hey, if you've had a TIA, this is your opportunity to take whatever steps are needed to prevent that stroke from happening. This is just a picture that shows you. So this is where we have the ischemic stroke. So the blood clot, what happens is there are carotid arteries, right? So we could get a piece of plaque or a little blood clot down in the heart, would travel up into the brain and in here, and it kind of lodges itself and it gets stuck, right? And then the hemorrhagic stroke over here is, you have all of these blood vessels, millions and millions of them. And think about if you have very high blood pressure, think about banging against that blood vessel wall. At some point, that is going to give way, and then you're going to bleed into the brain here. So let's talk a little bit about how do I know if I'm having a stroke. So my example of being, in the grocery store and you have this little episode. My mom used to love to say, oh, I had a little episode today, Suzanne. So if you have little episodes, I want you to pay attention. I want you to call 911. And I want, if you have a family member that has risk factors for stroke, I want you to learn what these symptoms are. Right, so that if you see them, you're going to call 911. So up until a couple of years ago, we used to just say FAST, face, arm, speech, time. However, balance and eyes also are symptoms, visual disturbance and balance for stroke. So now we say be fast, right? So balance, sudden loss of balance. It tends to be what we call listing to one side. You kind of get up to go and you go to the left or you go to the right. You have trouble moving your feet in front of you. The key that we are looking for is sudden, right? Not somebody who's kind of over a period of time been, they're becoming weaker and they're not moving around as much. This is sudden. Eyes, so vision loss. Now, what's interesting for our vision is that it can be one or both eyes. Other symptoms I'm going to talk about are one-sided, but with our eyes, it could be a problem in one eye or both eyes. And that's just because of how the blood flows into our eyes. So you could have total loss of vision, partial loss of vision. You could have what we call an amaurosis fugax, which is if you were looking forward in front of you, the sensation of a shade coming down over your eye, and you're sort of watching it come down as that happens. Those types of symptoms, we worry about stroke. Face, uneven smile, that facial droop. If something looks a little off, you ask the person to smile, and that's when you'll really be able to see that facial droop. Arm, you want to have somebody hold both arms out, and one may drift down. They won't be able to hold it all the way up if they're having a stroke. And then speech, any slurred speech, or could also be incomprehensible speech. Many times folks know they know in their head what they're trying to say, but it's not coming out correctly. And then time, right? So time is critically important. Two reasons, right? We want to make sure that we get care, we get to the ED as quickly as possible. We'll talk about the reason for that. But then we also want to know the time the symptoms started, because that will directly impact what care we can give a patient, right? So, if you're out and you're with your spouse or a mother or a sibling or a friend and you see they have these symptoms, also check your watch, check your clock. We have gone as far as finding a receipt in a patient's purse from Walmart, and we called Walmart had them pull the security tapes to see what time that patient was in line, because that was when we knew she was okay. So we knew her symptoms started after that. So time, two critical pieces with time, right? Right away, we want you to call 911. Don't waste any time. And then also note what time those symptoms started. A lot of folks will also have some other symptoms of stroke. We really key in on this be fast because this captures almost 98% of strokes. Sometimes folks will have little sort of, I don't quite feel right. I don't necessarily have weakness, but the side of my face feels a little funny. I have some tingling. So these are other stroke symptoms that we want folks to be aware of. And, here the sudden difficulty in understanding speech sort of goes back to speech, either slurred speech or speech that's coming out is not correct. That loss of balance. What we have found is, this is a new PR campaign from the American Heart Association. I think this gets lost. People are trying to figure all these 10 things. This is really what I want folks to concentrate on, the be fast. However, what's super important, now I have a question, is on your screen, do you see the stop sharing, or is that just something I see right in the middle of my slide?
I see it as well.
I'm not sure if
I can see it.
Okay.
If you hit hide,
all right.
it'll go away.
Can I do hide, or will that make everything go away?
No, you can click that.
Oh, perfect. All right. So here's the most important thing on this slide. It's okay to overreact and call 911. We don't ever want somebody to say, oh, I'm not sure. Oh, I don't want to be embarrassed if I call and it's not. No. It's okay to overreact, okay? This is the message, right? If nothing else from today, this is the message. It is okay to overreact and call 911. Let us tell you it's not a stroke, right? Rather than you wait and come in and we say, oh, it's a stroke and there's nothing I can do for you, right? So really important. It's okay to overreact. So we talked a little bit about time, making sure we call 911 right away. So why? Time is brain. Time lost is brain lost. So look at this, right? So every second during a stroke, so look at it, you see how many brain cells we lose. So neurons, these are the gray matter, it's kind of really what helps us live and do what we do. But look over here. So every second, our brain ages by over 8 hours. So for every hour you're kind of sitting at home wondering, should I, shouldn't I? Your brain is aging by almost 4 years, right? So this is the person that decided, so yeah, maybe I'll go to bed, see if it gets better, right? You wake up 10 hours later, your brain is basically 40 years older because of the damage that has occurred. So this is why we say every minute counts. So this is an interesting, just to kind of show you that when a stroke happens, this little area of red here, that's the stroke. That's, in my world, we call that the core infarct, right? I can't do anything about that. That damage has already happened. And lots of times, that little bit of damage isn't going to be a major issue. What we worry about, this tissue here, see the green tissue, all of this tissue has lost some oxygen and nutrients from the blockage, right? So I'm really worried. I want to make sure all of this green does not become red. That's my focus in trying to treat. Right, so if we look here, as more time goes on, like I said, we're going to wait. So now look how much that red area now has expanded. And this sort of tissue that I could probably save is getting less and less, right? Then you look at 3 hours, and after 6 hours, it's really difficult to kind of rescue any of that tissue that was there. So how do we treat stroke? So we have one medication, one IV medication that is approved for use through the FDA. There's a second one that will be approved probably midsummer. It's been used in Europe for a couple of years, acts the same way. So it's Alteplase. It's a clot-busting medication. It works quite well. However, it doesn't can't tell the difference between a clot that might be in your gut, or if you just had surgery and you're healing a wound. It doesn't know, so it's going to break up any clot that's in your body. So we do have to be careful what patients we give this to. If they've had any issues with, bleeding, either urinary bleeding, GI bleeding, any other types of issues that they're on certain blood thinning medications, we have to be very careful using this drug. But it works, right? We know that if we give it within 3 hours, patients do much better. We know, though, if we give it within 45 minutes of the patient getting to RED, they do even better than that, right? So, again, every minute counts. Now, more recent, up until about 6 months ago, we could only give this medication up to 4.5 hours after the symptoms started. At Crozier and a couple of other sites in the country, we are now giving it up to 9 hours. The reason we have to be really careful is we have to go back. We really have to look at the patient's imaging to decide if they would benefit from receiving it at 9 hours. So a patient here, I'm going to go ahead and give it to here even. But when they start to get to here, if I see no green, I'm probably not going to give it. We do have some patients, though, that at 6 hours, they still have a little bit of green there. So we may go ahead and give it. The beauty of Crozier now is we have a neurological ED. It's dedicated to just treating patients with neurological issues. So we're able to do some of these kind of more advanced treatments than maybe other places. The other avenue of treatment is what we call endovascular intervention. You may hear folks call it clot retrieval. And it really, I will tell you, that is like the history of the telephone. You start out with nothing, and then you had this type of phone, you end up with this, and you end up with this, and now you end up with your iPhone. So when endovascular intervention kind of came about, it didn't have a good reputation, partly because the wires and the instruments that were used, they were not very moldable. They were fairly rigid. They were fairly large. So if you try and stick something like that up into a blood vessel in the brain, you may not have good outcomes, right? But over time, over the past 3 to 4 years, these catheters have been refined. They work quite well. Actually, the neurosurgeon we have at Crozier is one of the folks that has invented 2 of the catheters that are now being used today. So for endovascular intervention, it's not available everywhere. It's only at select centers that are either what we call thrombectomy capable or comprehensive stroke centers. This room that you're seeing here is what's called a hybrid room. The unique feature of this is that a patient can come in here, and as we're working up here on their stroke, if something happens and we have to do something else, we can turn this table around and start another surgery without having to move them. The other piece that's really needed is if you take a look, this right here, here's the table, and then underneath, we're constantly taking images above, on the side, and below while we're in that patient's brain. So we have 3D real-time imaging so we can see where that clot is. This is just kind of another what it looks like. So this is actually a real patient that we had. So if you think back to the slide that I showed you earlier with the hours and the red and the green. So we look at her CAT scan and we can see, oh, wow, look at, so she's white, just cuts off abruptly, right? So here's that red that I was showing you. This is just more pictures of in the hybrid OR. So what happens is we give contrast to the patient, and then we look at the blood flow in their brain, and we look to see where that clot is. So this is the actual catheter. Now this is magnified, so it looks much bigger here, but it's very pliable. And what ends up happening is, here's the blood vessel up in the brain. This is the clot here. This catheter is going to be, we're going to advance it up. We go in now, we go just like a cardiac cath. We're using wrists now instead of groins, unless we have to. So, you know, it's great. We're not, you know, we go right into the wrist and it's much easier. So we kind of just go up like a cardiac cath. We're going to go up through the blood vessels, through the heart, into the carotids, up into the brain. This little guide wire goes up into the clot. And then we deploy what's called a stent, because as we are trying to suck that clot out, we have to make sure that the blood vessel doesn't collapse on itself. So this is kind of what it actually looks like. And this is where it's going to go up through the clot, right? So again, and then we always go above the clot, because we're going to have to pull back towards and pull that clot out. Actually, we're sucking it out. So we snake it up, right? And then we deploy that little stent basket there. Start to pull it back. And as we're pulling back, we're also suctioning, right? So you're kind of seeing it coming back and coming back and coming back. This is what came out of that lady. This is, remember the one I just showed you up here? Right? Remember right there? Now, let's go down here. I think this is just so cool. So this is that. Now look at, look at all that blood flow there. This amazing, amazing. So all of the literature supports doing this procedure up to 6 hours. We are doing this up to 24 hours for patients. It depends where the clot is in the brain for how easy it is to get to. But this is a life changer for folks. I have had patients who in the past would have ended up in a nursing home with a really severe disability. And we take them up to the OR, we suck the clot out, and they go to rehab in 2 days and they go home in 2 weeks. So definitely has made a huge impact. So now that we've talked about how we're going to treat strokes, right? As I said in the beginning, we need to figure out how to help folks not have a stroke, like basically put me out of business. So there are a couple of things, risk factors that we can't do anything about, right? Age, sex, race, family history. I can't do a blessed thing about any of that, right? So the older I get, my risk goes up. Male, female, after menopause, it kind of equals out, right, for having stroke. We already talked about race with African Americans and Hispanic. We also, in the Asian population, we see a much higher rate of hemorrhagic strokes, and we think that that's probably diet related. They have lots of vitamin E and other dietary intakes that we think could influence that. And then family history. So, you know, you can't help if your mom or dad had a stroke or a heart attack or, you know, may have some genetic cholesterol issues. You can't do anything about it. So let's work on what we can do something about, right? So we already talked about high blood pressure. And Margaret, if you need to cut me off, okay? Because I'll talk forever. Heart disease, AFib.
Oh, okay, you're fine. You're fine, Suzanne. I will have to get off at 2 because I have another meeting, but you're fine.
Okay, so whoever then is going to be monitoring it, just kick me off, okay? Because I will talk forever. So cigarette smoking, I hate that I even have to put this up here, but I also appreciate how very difficult it is for folks if they are smoking to stop. Here's the problem with smoking is every time somebody smokes, every blood vessel in their body constricts, right? So imagine you're going to constrict, not constrict, constrict, not constrict, constrict, not constrict. You know, at some point your blood vessel is going to just give up and say, I'm done. I have to actually go, I have to grab I have to be able to plug my phone in because I think it's going to die. So let me, and I don't think it's up here. Well, we'll see if we can get through here without that happening. So obesity, I can tell you that in Delaware County, our rates for obesity are going down slightly. However, the rate for overweight is going up. So we still have work to do on that. And then diabetes. The issue with diabetes and stroke and kidney failure is diabetes makes our blood vessels very brittle, right? So imagine you have these little tiny blood vessels. They're very brittle. They're very fragile. And then you have high blood pressure on top of that. So at some point, those blood vessels are just going to give way. So either they're going to stop working so no blood gets to that area, or they're going to rupture like we showed in the one picture for the hemorrhagic stroke. And then elevated cholesterol and lipids, another big, those of us in the stroke world, we would love to have statins in the water, but, that's not obviously going to happen, but, they do make a big difference. So let's talk a little bit about high blood pressure. So I mentioned with diabetes, for instance, the tiny fragile blood vessels that are affected. So what happens, so here, in our heart, so the blood starts here. As the blood has to travel further away, the blood vessels get smaller, 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 smaller. So by the time they get to our brain, they're small. Get to our eyes, they're small. They get to our kidneys, they're small. So, of course, that's why when you're hypertensive or diabetic, you have stroke, you have visual problems, you have a heart attack, and you have kidney disease. So we really have to be on top of all of it, right? So it's not just diabetes, and it's not just hypertension, and it's not just stroke, right? Kidney disease is included too. So talk a little bit about the change in numbers, and I don't want people to panic because they're going to say, oh my God, my pressure today was 140/90. So, it's not a one-time blood pressure. We really advocate that folks routinely check their blood pressure so we can see what the trend is. So we now are saying that less than 120/80 is normal. If you are 139 and your bottom number is 80 to 89, we're going to start saying, yeah, you have high blood pressure. 140, your top number 140 higher, or your bottom number 90 or higher. We're starting to treat folks in this category now, where before we didn't, we weren't as aggressive. Again, a reading here or there of 140/90 is not what I'm talking about. This is sort of, you're continually reading 140/90 or higher. Oh, I'm going the wrong way. Sorry. So just a little bit about blood pressure. So there are two numbers. The top number is what we call our systolic. Bottom is diastolic. The reason there's a difference, the top number is the pressure that's being exerted against our arteries when the heart's actually beating. The bottom number, the diastolic number, is the pressure that's being exerted against the artery walls while the heart is resting. Now, it's only for a minute, right? Because our heart beats pretty frequently. So that's the difference between the top number and the bottom number. In most people, as we age, the systolic gets higher because our blood vessels just are not as pliable as they were at one time. They start to get stiff. We may have plaque buildup. So we do tend to see that top number going up as we age. What we are starting to see from some really good studies, that what we call longitudinal studies, so over years, is that the risk of death from either heart disease or a stroke doubles with every increase of 20 for your top number or 10 for your bottom number, right? So really important that we get those numbers under control. And again, it's not a one-time reading. This is where, you know, over a period of a year or two, you've gone from 160 over 80 to 180 over 90 and then you stay there. This is not good, right? We know that now. So cholesterol and lipids, why are they a problem? Well, so first of all, our body needs cholesterol. It helps our, you know, think of your body as like a manufacturing plant. It's like a refinery. You know, it kind of needs crude oil and stuff like that to operate, and then it gets rid of stuff. So we need cholesterol, but our body already makes it for us. You know, so we don't need to be taking in a lot of extra cholesterol. Problem is, it's a waxy, fat-like substance. So think about that, right? Like waxy, fat-like. Okay, well, you don't want a whole lot of that. So as I said, we make our own. Our liver makes it for us and generally makes all we need. Some folks, it makes way more than they need. But then we also take it in through our diet. Oftentimes, the foods that are high in cholesterol are also high in saturated and trans fats. And I'll go over that in a minute. What happens then, if we have a lot of saturated fats, then we better not have trans fats anymore because they've been banned. That actually kind of kicks our liver into overdrive and it makes even more cholesterol. So what happens then, the cholesterol joins with these other substances, and not only a waxy fat-like substance, but it actually becomes a plaque. It actually becomes this kind of hard piece of gunk that just sticks to the blood vessel wall. So lots of folks talk about their HDL and their LDL. So those are lipids. And we need both of these because these actually help our body get energy into and out of the cells, right? So HDL, happy, H for happy is what we call the good cholesterol, right? So healthy HDL. This is a good thing. This is what we call the good cholesterol, right? Women, until menopause, we tend to have higher levels of HDL. That's a good thing. But that's why after menopause, our risk of stroke kind of is the same as it is for males. One of the things that the good cholesterol does, it actually carries away the bad cholesterol, right? So it pulls the bad cholesterol from the arteries and it deposits it back into the liver, where we then break it down and we excrete it, right? So just like the refinery. So we really want to make sure our HDL is where it needs to be. So LDL bad. So this comes from a diet high in saturated, and again, trans fats should be out of the picture. We do not need any of this LDL cholesterol, so it's not like we have, this is not a dietary need. We don't have to be seeking out foods that have LDL cholesterol, right? We know that LDL really, really contributes to these fatty buildups in our arteries. And then triglycerides, just quickly, again, it's another form of fat that's in our body that's necessary. But we know that if we have high triglycerides and then we have a high LDL, which is the bad cholesterol, or a low LDL, these are folks that have really, really big problems with atherosclerosis. Lots of, you'll see their femoral arteries start to get kind of clogged, and these are the folks, their legs get cold, their feet get cold because the arteries just aren't working. Talk a bit about sodium. You know, linked to high blood pressure. So sodium is a mineral that we actually need, right? It's essential for life. It's regulated by our kidneys. It's actually needed for our nerves to work correctly in our muscles, but too much is not good, right? Table salt. Now, there is a difference between sodium and table salt. The table salt that you buy at the store is actually sodium and chloride, right? So the table salt we use is about 40% sodium. So when you buy the salt substitutes, you'll find there's a lot of much higher degree of chloride in there. Is why they kind of taste very sour is not the right word, but they have like a bitter taste to them. We need to be really mindful when we are shopping. Where does the sodium come from? The majority of it, processed foods, okay? I know lots of people tell me, well, I stopped using salt at home. I'm like, well, that's great, but you know what? Only about 10% of the total amount of salt you use, you're actually using at home. When you look at everything else that you're bringing in from home or eating out, that's where the majority of our sodium intake occurs. So be real mindful of that. You want to be looking at your labels to see how much sodium is something. The next time you're out, look at a can of soup and see the amount. One serving of soup is higher than the daily recommended amount of sodium. One serving, right? So what is that serving? 1,500 milligrams per day, which for people that are used to having lots of salty things, that you're going to panic because you're going to be like, oh my gosh. But when you start to cut back on your salt, your sodium, do it gradually. I guarantee if you do it cold turkey, it'll only last a week. So just start gradually cutting things out. Pay attention to labels. The more you're aware of what's in your food, then you'll be more mindful of it. And these are all things that I can certainly send to somebody, their handouts, if anybody is interested in them. People don't realize breads and rolls, look at those packages. Some of those highly processed breads have lots of salt in, as much salt as pretzels or potato chips do. So talked a little bit about fats earlier when we were talking about the lipids. So fat, it's definitely something we need. It's the major source of energy for our body. We have fat-soluble vitamins that are required, to live. So we need the fat to help absorb them so we can use them. And all fats basically have the same chemical structure. All fats have the same calorie count of 9. But what makes the difference in fats is basically how they're put together chemically, right? And let me show you. I'll just quickly go to here. So not that this is a chemistry test at all, but this is the chemical structure if you take a look at the different types of fats. And this is what makes them bad or makes them good, right? So with fats, the one thing is saturated, not good, right? So think of if something is saturated with something, that just doesn't sound right, okay? These are fats that are solid at room temperature, not cold, at room temperature. So think about Crisco or Oleo or something. Imagine you're putting that in your body. What does that do in your body, right? It's gonna end up sitting somewhere. That's the bad fat, right? Unsaturated is what you want to look for, okay? And the unsaturated fats are liquid at room temperature. Now, it'll get a little bit confusing because then we have monounsaturated and polyunsaturated. I'll tell you, just worry about unsaturated. Try to avoid saturated, okay? Trans fat, now this, I will tell you that there are still some, especially in a lot of our, some of our ethnic communities that will import trans fat or foods made with trans fat. Here's the issue with trans fat. It's a byproduct of this process called hydrogenation. So there's not one blessed natural thing in that, right? It's not safe for human consumption. So just be very aware of that if you might be kind of eating in an area that has like a very high cultural plethora of restaurants and things that may still use a trans fat. Let me show you. So here, just the good, the bad, the ugly, right? Go for your polyunsaturated and monounsaturated. Try to avoid saturated if you can, right? Sometimes you're going to have some, but these hydrogenated oils in your trans fat, try to avoid at all costs. We don't want you to be sitting around either, okay? Here's the most important thing. Whatever you do, something is better than nothing, okay? If you're on the phone, pace around, walk around, go up and down the steps, right? If you're working, get up, sit down, get up, sit down. This is my favorite, but I stopped doing it. Park farther away. Make yourself walk in the parking lot, either from work, from the parking lot to your work, or if you go to the mall. Walk around when you're looking at your phone. Do things in person rather than calling or emailing. Anything is better than nothing, okay? Really, we advocate for 150 minutes a week. So if you can get that in, you'll be doing yourself a huge favor. So let's quickly talk about what happens when you think somebody's having a stroke, right? So 911, absolutely going to be essential to having a good outcome, right? So when you're calling 911, we always want you to say, I think they're having a stroke, because stroke now is handled like trauma, right? So when you see that trauma on TV and all of the paramedics get there and they swoosh in and swoosh out and they get to the hospital and everybody's waiting for them, well, that's what we do for stroke now. So when you say stroke, you are getting a paramedic and a medic, maybe two paramedics. You're not just getting a medic or an EMT. Make sure you say stroke. If you're calling on a cell phone, it's always good to right away say where you are, because if that call gets dropped because you walk around the corner of the house, it's real difficult to get back to some cell phones, right? We talked about noting the time. And then you're going to want to tell the 911 dispatcher what you saw, what you heard, what's going on. They have a facial droop. They're drooling. They're not making sense. We want you to stay with that person. 911 dispatcher is going to keep you on the line if they think that they need to be in touch with you until the ambulance gets there. So we don't want you to ever hang up until the dispatcher says it's okay to hang up. Make sure you're keeping that person safe, right? We want to make sure they're not laying flat. Make sure they don't have any any tight clothing on them. And this is the most difficult one, remain calm, right? And the 911 dispatchers they're pros at helping folks with that. Now, a couple of other things. Unlock the front door if you can, okay? Put on a front light. If there's somebody else in the house that can go outside and wait so that the paramedics can easily identify the house, okay? If you have to start doing CPR, don't panic. If you don't know how to do it, dispatcher's going to walk you through it, okay? Always, again, the sooner the patient gets treatment, the better. So that's why 911. They're going to ask you, all right, where's the patient? Is it a male, female? Do you know how old they are? Give me a callback number. What's your name? Again, that's so when they get to the hospital, I might have a question and I may need to call you to ask you exactly what you saw, especially now with COVID. families are not coming in with the patient, so we always like to have that callback number and a name. Again, try and remain calm. We talked about turning on lights. Open any locked doors. Keep in mind apartment buildings. I can tell you that EMS are expert at breaking doors down, so they will get in, right? They will not hesitate. And I can also give Margaret the information. If you either live by yourself or you may have trouble getting around your house, you can always place a key safely somewhere on the outside, and you can contact the 911 dispatch center and give them your address and let them know where that key is. Or if you have like a keyless entry, you can give them that number and it'll be logged in, so that if you live at 10 Marrow Road and they're on their way, they'll pull that up and it may say, oh, you know, the patient's in a wheelchair and the key is located under the doormat behind the whatever. All right, so another really great feature, sometimes good for parents too, if you want to make sure that folks know, the paramedics and dispatch folks know how they can get in the house. Again, we want to know, when did those symptoms start? And if you don't know if you didn't see when they started, can you help us? When was that patient last normal at their baseline, right? Tell us what the symptoms are. If at all possible, we'd ask that you be able to give us some medical history, allergies, medications. Other really good thing is, if you can, and I can make sure Margaret sends these as well, keep a medication list for yourself or your spouse or parent on the refrigerator. The joke of cops always eat donuts. Well, let me tell you, paramedics always go to refrigerators to look for key information, right? So that is a universal location for any type of personal information, medication list, allergies, etc. And we have some kind of standard templates that we could share with you. So it's always good to be prepared. You could work on that and have it done, so you're not trying to do it at the last minute. And then I just want to quickly go over a little bit about stroke and COVID. So this is what we know. We know that folks who have severe sepsis, septic shock, and severe respiratory infections, totally unrelated to COVID, we know that they have a higher rate of stroke once they get in the hospital. So it would make sense that with COVID, we would see more stroke. If you take a look at this one statistic, there's up to a 5-fold increase in stroke in patients in the first 2 weeks after they've been diagnosed with severe sepsis. So part of what we're seeing is exactly what we would see in a patient that would have sepsis. We also know that with COVID, the way it works, it increases the inflammation throughout the body, right? So everywhere in the body, your lungs, your brain, your gut. When you have inflammation like that, you then also become very prone to forming clots. So thrombosis, those are clots. The interesting thing is we see clots in the arteries and in the veins with these patients. So we know that just physiologically that it would make sense for COVID then, because of the increased inflammation and increased blood clots, that we would see increased numbers of stroke. But we really have not seen that. We do have to wait. So there have been reports out of New York and Spain, younger folks are having strokes and they're having bad strokes. But what we have seen on the other end is patients are not coming to the hospital. Across the world, there was a dramatic decline in the number of what we call stroke alerts. So these are patients that are coming in by EMS for stroke, a dramatic decrease. So, you know, in the medical field, what we don't know is, it just looked like it's a really high rate of stroke because, you know, the denominator is not that big right now. So if I had, you know, think about the stadium at the Super Bowl. When that stadium was jam-packed, if 10 patients had a stroke, we never would have noticed, right? But when there were only 2,200 people there, if 10 people had a stroke, it would have been, you know, oh my God, like the whole world was having a stroke. So we do have to wait to see over the next like 10 to 12 months how those numbers pan out. But I do think what we're going to find is that patients who have severe COVID already have COVID. Those are the patients that we're seeing having strokes. And there have been a couple of studies that the clots, like we talked about, up in the brain are kind of a bigger, harder type of clot. But again, it's one or two doctors who are reporting this. So when we talk about statistics, we really want to make sure we have data over a period of time. So in some ways, I worry people are going to say, oh my God, I have COVID, I'm going to have a stroke, or I'm not going to go to the hospital because I'm not going to get COVID. I'm going to get COVID if I go to the hospital, and then I don't want to have a stroke. We're not really seeing that. The more important thing here is that patients have not been getting to the hospital when they have stroke symptoms. This is our data right here at Crozier, right? So in 2019, our patients got to us within 280 minutes of symptom onset. Well, you know, through 2020, that's gone up almost 30 minutes, and that can make or break a treatment decision. So I really want patients to worry more about getting to the hospital if they have stroke symptoms rather than worrying about, oh, if I get COVID, I'm going to have a stroke. Because really the jury is still out on that. I do think after a period of time, we will be able to see some type of relationship. It would make sense because of the inflammation and the clots. But right now, the more dangerous thing that we're seeing is that patients are not getting to the hospital. And then what happens, you know, this is very morbid, but what we are really seeing is, you know, somebody hasn't talked to their mother or their father or their friend for a couple of days. They go over and they find them that, you know, they've been there for 2 or 3 days because they refuse to call anybody. And now they're way beyond any type of intervention we can do. You know, if they had just kind of come in the beginning, we could have helped them. So that's kind of my piece on COVID. I don't want folks to not come to the hospital if they have chest pain or stroke symptoms because of COVID. That we have to try and help folks understand they still need to get here. And again, don't ignore the symptoms. And that's the end. So I don't know if folks have questions or if there are any of the handouts or any information you want me to send to Margaret. Just let me know. I'd be happy to do that.